I'd like to introduce our presenters this evening. I'll start with first Rosina Triptova is a senior respiratory physiotherapist, I do apologise, at the Intermediate Care Respiratory Service, Salem. She provides specialist respiratory physiotherapy in an airway clearance clinic for bronchiectasis. Thank you, ladies. COPD and neuromuscular conditions, and is involved in pulmonary rehabilitation program at No Longer GP Club. She has also developed and implemented the HERO program, home respiratory rehabilitation for patients following an exacerbation of COPD requiring hospitalisation. And brings the background of experience in ICU. I'd like to welcome Dr. Kerry Hancock. She's a GP-based business owner at Chandler's Hill Surgery, Happy Valley, for the past 35 years. She's a Specific Interest Network RACGP Foundation. She's the chair of the advisory committee and a member of the Clinical and Research Council, previously National COPD Program. He's also a member of the Lung and Cancer Advisory Group for Cancer Council. Dr. Sally Chapman is a respiratory and sleep physician who graduated from University of Adelaide and who undertook her specialist training at the Royal Adelaide Hospital. She's a founding director of Respiratory Consultants and holds a public hospital appointment at the Royal Adelaide Hospital. She has interest in all aspects of respiratory medicine, with particular interest in management of airway disease. I'd like to welcome all three of the presenters. Thank you very much. Thank you.
Good evening, everyone, and welcome to the presentation. To start, I will be just giving a introduction to COPD. I'm happy to take questions, but I suspect a lot of them will be covered by my talk, and so I'll probably hold most of them to the end, but please feel free to pass them forward. Oops, first technical glitch. So COPD. Well, why are we interested in COPD? So the prevalence of COPD in Australia is estimated to be somewhere between 10 and 14% of people over the age of 40. It's the fifth greatest contributor to the overall burden of disease and one of the most common causes of death in Australia. The cost to the Australian community is estimated to be 8.8 billion annually, and that includes health and hospital costs, lost productivity, premature death, and decreased employment. It isn't a disease that stands alone. It's often associated with other chronic diseases, including heart disease, lung cancer, stroke, pneumonia, and depression. What causes COPD? Smoking is the most important risk factor in COPD development. Around 50% of all smokers will develop some airflow limitation, and around 15 to 20% will develop clinically significant disability. Smoking cessation will slow the rate of decline in lung function, but will not improve lung function. And this is the figure of time course of COPD from Fletcher from 1977, which indicates that if you're a never smoker, your lung function will decline with age. But if you're a smoker who's vulnerable to the effects of cigarette smoking, your lung function will decline more rapidly. If you're able to give up smoking, then at least on a population basis, your lung function decline will go back to that of the general population. Other risk factors for COPD, genetic factors, alpha-1 antitrypsin deficiency is the classic, but also those smokers who have a family history and other family members with COPD are themselves more likely to develop COPD. Occupational dust exposure is becoming an increasing risk factor for COPD as smoking rates decline, and it may be responsible for 20 to 30% of COPD, and that includes mineral dust, biologic dust, gases and fumes. An interesting contributor to COPD, particularly from those from areas such as Afghanistan, is indoor air pollution from biomass cooking fuel. That's not such a problem in our society, but with immigration, it is something that we're seeing more of. Outdoor air pollution, cities that areas, for example, in China with high air pollution have increased COPD rates compared to country areas, and it also is more common in lower socioeconomic status. That's not exactly clear of the reasoning behind that, but it may relate to increased smoking, greater exposure to pollution, more respiratory tract infections. So COPD is a preventable and treatable disease. It's characterised by airflow limitation, which is not fully reversible. The airflow limitation is usually progressive. And in clinical practice, the diagnosis of COPD is usually based on symptoms such as exertional breathlessness, cough and sputum, a history of smoking or exposure to other noxious agents, and quite significantly, and part of the diagnosis, an FEV1 to FVC ratio of less than 0.7 post-bronchodilator. So history, as I've said, symptoms are generally not very specific. Breathlessness, progressive, characteristically worse with exercise, which really goes along with a lot of respiratory conditions, cough, sputum production, but other symptoms like chest tightness and wheeze. A history of risk factors, tobacco smoke, but also occupational dusts, vapours and fumes, and assessing the impact of symptoms on activity is important. Examination is a poor way of making a diagnosis of COPD. Its sensitivity for detecting mild to moderate COPD is poor. In advanced disease, you may see chest hyperinflation, reduced chest expansion, soft breath sounds, and prolonged expiratory phase. Right heart failure may complicate severe disease, and so peripheral edema and signs of right heart strain may be seen. It is impossible to determine the presence and severity of airflow limitation from clinical signs. And I've also added, or from a chest x-ray. You cannot diagnose COPD on a chest x-ray, despite what many radiologists will have you believe. Spirometry is absolutely essential for the diagnosis of COPD because by its definition, it is chronic obstructive pulmonary disease. You cannot determine airflow obstruction without spirometry. So COPD is defined by the demonstration of airflow limitation, which is not fully reversible. And airflow limitation is not fully reversible when a post-bronchodilator, the FEV1 to FVC ratio is less than 70% and the FEV1 is less than 80% of the predicted value. Misdiagnosis of COPD. So this is an interesting article published in the Medical Journal of Australia in 2018. This is one of many studies, but it illustrates quite well that clinical diagnosis of COPD is not always accurate. So 1,050 smokers or ex-smokers from 41 Melbourne general practitioners were surveyed, and it was found that greater than a third with a prior diagnosis of COPD did not meet the spirometric definition for COPD, and that 1 in 6 that were not previously diagnosed with COPD had spirometry consistent with COPD. So what we're seeing is both over and under diagnosis of this condition. One of the things that's important is to assess severity, and there are a number of tools for doing this. This is the Lung Foundation Australia's sort of stepwise management of COPD that looks at mild, moderate and severe COPD based on symptoms and lung function. So generally we'd classify mild COPD as few symptoms, breathlessness or moderate exertion, cough and sputum production, and little or no effect on daily activities with an FEV1 in the range of 60 to 80% predicted. Moderate, breathlessness walking on level ground, increasing limitation of daily activities, recurrent chest infections, exacerbations requiring oral corticosteroids and or antibiotics, and an FEV1 in the 40 to 59% predicted range, and severe with increasing breathlessness or minimal exertion, daily activities severely curtailed, exacerbations of increasing frequency and severity, and an FEV1 of less than 40% predicted. Unfortunately, most of our patients don't fit neatly into one of those boxes and may have poor lung function but minimal symptoms, or a lot of symptoms and well maintained lung function. Other classification criteria include the GOLD classifications of GOLD 1, 2, 3 and 4, which is really based purely on spirometry. And another way of looking at the severity is to look at dyspnea scales, which can use the modified MRC dyspnea scale, which is actually quite a simple one to use. So 0, 1, 2 and 3, with breathlessness increasing from only strenuous exercise to too breathless to leave the house. The CAT assessment is one that has been used in general practice to look at the severity of COPD. It's, I guess, a bit similar to the ACQ-5 for asthma, and it's relatively simple and it's subjective. It depends on the patient's perception, and this is can be used as a screening tool and may be useful to monitor progress in COPD over time. And then the tool that is perhaps beginning to be used in terms of some of our guidelines in terms of treatment is the refined ABCD assessment tool. This incorporates a diagnosis of COPD, assessment of airflow limitation using the GOLD criteria, and then an assessment of symptoms and risk of exacerbation with hospital admissions, and the CAT or modified MRC score providing the symptom basis. And so that gives us 4 categories, and we'll get to this later because this reflects where we potentially go for treatment. A tool that's used perhaps more for research is the Bode index, and this is probably more used in either research or in looking towards more extreme treatments such as lung transplantation, because it is one that does look at mortality. And you can see that if you have a Bode score of 0 or 2 points, your 4-year survival is 80%. Well, if you've got 7 to 10 points, it's 18. So this looks at features such as the FEV1, 6-minute walk test, dyspnea scale score, and body mass index, and perhaps is not as useful on a day-to-day basis in general practice, but it's certainly a tool that I would use in considering more extreme treatment measurements in selected patients. One of the things we're often asked is COPD versus asthma. And this is very simplistic because there is overlap. One of the things that is worth noting is that if we look at COPD trials, they exclude patients with bronchial reversibility. If you look at asthma trials, they exclude patients who have smoked generally more than 10 pack years. So there's a large group of people who we see in routine daily practice who actually don't meet the criteria for pure COPD trial defined or pure asthma trial defined, and have fit between these categories. So we actually probably don't know the optimal way of treating a large majority of our patients. So COPD generally has onset over the age of 40. It's a progressive disease. Most commonly it's found in those who've smoked for more than 15 pack years, and the airflow limitation is not completely reversible. Asthma traditionally has an earlier onset, more variable symptoms, less smoking, airflow limitation, which is substantially reversible, and more common to have atopy or other signs of allergy. However, COPD can coexist with asthma, and that's suggested by a significant bronchodilator response on spirometry, and long-standing asthma can lead to fixed airflow obstruction. And that's beyond the topic for tonight, because you can come to a Thoracic Society meeting and have a 3-hour symposium on whether asthma with fixed airflow obstruction is in fact COPD. So it's still a matter of somewhat semantics and definitions. So what further investigations would you do if you're looking at COPD? So investigations may help to confirm or exclude other conditions and assess the severity. Complex lung function testing can look at static lung volumes, diffusing capacity, and arterial blood gas. Exercise testing can be to the extent of cardiopulmonary exercise testing or 6-minute walk testing to assess functional capacity and requirement for oxygen with exertion. Sleep studies may be helpful to look for coexisting COPD and also to look at overnight oxygenation. Radiology, as I said, a chest X-ray does not diagnose COPD. It might show hyperinflation. They are not the same thing. and CT chest are perhaps looking more for complications such as lung cancer, but also to assess the extent of emphysema. Sputum cultures can help guide antibiotic therapy. However, a lot of people with COPD may be colonised with bacteria, so the finding of bacteria does not indicate the need for treatment. Echocardiograms may be helpful to look for evidence of right heart failure. So the next step, once we've made the diagnosis, is to look at treatment. And I'm just going to go briefly through the sort of pillars of treatment: smoking cessation, medications, non-pharmacological therapy, treatment of comorbid conditions, oxygen, interventional treatment, and palliative and supportive care. And I'm really confining myself to the treatment of chronic COPD and not going into the treatment of exacerbations during this talk. So smoking cessation. Smoking cessation reduces the rate of decline of lung function. Personalised smoking cessation advice increases cessation rates, and that can be something as simple as asking about it at each consultation. Pardon me. Patients expect to be asked about their smoking. Often we think we'll be offending people, but you know, if you go to a respiratory physician, they expect you to ask about smoking. If you're going to your GP with regard to your lungs, people expect to be asked about smoking. They might not like that they're still smoking, but their acceptance of smoking is not a good thing by medical practitioners. Pharmacotherapy and psychological support increases cessation rates, and I'm not really going to go into a lot about smoking cessation because that's a whole topic for another evening, but long-term abstinence rates do vary by treatment method, with the use of medication such as and support producing increasing quit rates compared to those who quit unassisted. But you can see even with the best outcomes, we're still looking for an individual attempt at quitting of rates of around 30% being the sort of optimal. Medication. So I'm going to go through the individual classes of medications and then sort of look at where they fit in terms of the different severity of COPD. The first group of medications that's often used in COPD is short-acting beta agonist, and it's usually prescribed as needed. Compared to placebo, it improves breathlessness and there's some improvement in spirometry. There's no significant benefit on functional capacity measured by walking tests. Short-acting muscarinic antagonists are no longer really called anticholinergics because they actually work, although that's part of their property, that's not the whole mechanism of their action. They tend to have a longer duration of action than the short-acting beta agonists, improvement in spirometry that's comparable to short-acting improvement in spirometry when compared to the SABAs, and improvement in quality of life. Some of the initial studies suggested a possible increased risk of cardiovascular death with the use of SAMAs alone. So long-acting muscarinic antagonists, they result in bronchodilation with a duration of 12 to 24 hours depending on the drug, and compared to placebo they result in improvement in lung function, symptoms, quality of life and decreased exacerbation rates. The adverse effects are generally manageable with dry mouth, constipation and urinary retention all being seen. So if we're looking at short-acting muscarinic antagonists versus long-acting muscarinic antagonists, a Cochrane meta-analysis comparing tiotropium with ipratropium bromide for people with stable COPD. The tiotropium, which is the LAMA, was associated with improved lung function, fewer hospital admissions, fewer exacerbations of COPD and improved quality of life. There were also fewer serious adverse events and disease-specific events in the tiotropium group, but no difference in mortality. Long-acting beta agonists result in bronchodilation, the duration of 12 to 24 hours, similar to the LAMAs. Indacarol is available in Australia on PBS as a single drug for COPD. And Indacarol and other LABAs are available in Australia on PBS in combination, LAMA LABAs, ICS LABAs, or triple combination. So LABAs result in improvement in dyspnea, FEV1, health-related quality of life, and reduce exacerbations. One of the big questions is LABA versus LAMA. So a Chen meta-analysis looking at this showed that LAMA was associated with a lower risk of acute exacerbations with a significant difference in odds ratio, associated with a lower incidence of adverse events, no significant differences between them in changes in lung function, symptom score, health status, and serious adverse events. And the conclusions was that a LAMA may be preferable to a LABA, particularly in those at risk of frequent exacerbations because of the decreased risk of exacerbations that was seen. What about the combination? We have 4 fixed-dose LABA-LAMA combinations in Australia that are delivered in a variety of devices. And overall, compared to the individual components, the combination results in greater bronchodilation, improvement in dyspnea and quality of life, and decreased exacerbations, particularly when you compare them to a LABA alone. So the LAMA, it seems to have a greater effect on exacerbations. It seems to be a class effect. There's not a lot of head-to-head comparisons between different combinations. Inhaled corticosteroids is a monocomponent, decrease exacerbation rates, slow the rate of decline in quality of life, but no change in mortality, and no consistent reduction in the rate of decline in FEV1. They do come at a cost of increased risk of oral candidiasis, voice hoarseness and dysphonia, and increased risk of pneumonia. And at present, there is no PBS approved ICS monocomponent for COPD in Australia. Combination ICS and LABAs decrease the rate of exacerbations, and it's estimated that combined ICS LABA would lead to a reduction of 1 exacerbation every 2 to 4 years. They improve health status, they improve lung function, but they increase the risk of pneumonia. They don't increase the risk of hospitalisations and deaths. If you compare ICS LABA versus LABA alone, the ICS LABA does have decreased exacerbation rates, improved quality of life, improved FEV1, no difference in hospitalisations or mortality, but an increased risk of pneumonia. And if you compare ICS LABA versus ICS alone, the combination has decreased exacerbations, decreased mortality, improvement in lung function, and improvement in health-related quality of life. So there is really little support for the use of ICS alone when LABAs are available. The next big comparison is really the different combinations. So LAMA-LABA, of which we have 4, versus ICS LABA. And a Cochrane review from 2017 compared these. What they found was the combination of a LAMA-LABA compared to the ICS LABA resulted in a small reduction in exacerbation rate, no significant change in quality of life, small improvement in FEV1, no change in mortality, but significantly less pneumonia. And this supports the use of LAMA-LABA over ICS LABA for the average patient with COPD. What about a combination? So if you add a LAMA to an ICS LABA, you get a small improvement in FEV1, slight improvement in health status, and slight decrease in rescue medication. And if you compare them to the individual ones, so compared to LAMA alone, compared to ICS LABA, and compared to LABA-LAMA therapy, we do see improvements in terms of decreased exacerbations, and that seems to be across the board. The triple combination seems to be better than the individual combinations, bearing in mind that most of these studies were done in those with severe COPD and frequent exacerbations, so they may not be generalisable to people with milder lung disease. So patients with severe COPD and frequent exacerbations may benefit from ICS LABA-LAMA therapy rather than dual therapy with an ICS LABA or a LAMA-LABA. It's a tongue twister. Interestingly, there's been no difference between the fixed triple therapy in a single inhaler and separate triple therapy. And in Australia, it's important to note that for initiation of single inhaler triple PBS subsidised therapy, the patient must have experienced at least 1 severe COPD exacerbation, which required hospitalisation, or 2 or more moderate exacerbations in the previous 12 months with significant symptoms. despite regular bronchodilator therapy with LABA and LAMA therapy, or be on stabilised on a combination previously. So they're not ones that you can just initiate de novo. So once you have all the medications, how do you actually look at using them? And this, there are a number of different approaches. This is the Lung Foundation Australia's stepwise management of COPD. And this goes back to their categories of the mild, moderate and severe lung disease with the FEV1s according. So generally the first principles are the ones that we talked about to start with, which are to reduce risk factors, optimise function, treat comorbidities, which I'll get to in a bit, and then to look at medication. So generally speaking, the initial recommendation for someone with mild COPD is to start with a short-acting reliever. Generally that would be a SABA, but there can be a SAMA if there are contraindications to that. Possibly then add a long-acting bronchodilator. Perhaps a LAMA has a slightly better side effect profile, and then as you move through to those with moderate disease, you would potentially increase the treatment to dual long-acting bronchodilator therapy, and those in the severe category may benefit from triple therapy. So that's a very sort of treatment sort of regime based upon the severity of lung function. Now, if you go back to the ABCD, where you had combining exacerbations and symptom score. So group A are those with low symptom score and 0 or 1 exacerbation. In this group, you would potentially start with a bronchodilator. In people with low symptom scores but more frequent exacerbations, they may benefit from a LAMA as first-line therapy. If you have somebody with few exacerbations but increased symptoms, a long-acting bronchodilator may be the best choice. And if you have the group of people who have frequent exacerbations and high levels of symptoms, then the combinations that you may look at starting would be a LAMA alone, combination LABA-LAMA or ICS-LABA. So this is perhaps a more pragmatic solution because it takes into consideration both symptoms and exacerbations rather than relying purely on lung function, which isn't always a reliable indication of the impact that has. So stepwise management, and I show this, and I'm sure no one in the audience does this, but because we have so many different combinations of treatment, it's very important to know what's in the inhaler that you're giving somebody, because it is not infrequent that I find people who are on 2 LAMAs or an inhaled ICS LABA plus a LABA-LAMA, so well, they're duplicating. So you can see that there's actually not that many combinations that can be used with other things. I've also put a box around the LABA, salmeterol and formoterol, because these are actually not PBS listed in Australia as sole treatment for COPD. So they are indicated for asthma. But this is part of the Lung Foundation Australia's stepwise management. So they have this available either on their website or as downloads, so you can look, oops, sorry, I've done something silly. Look at seeing if you're wanting to add another medication, which ones go with which. One of the things that is very important when you have somebody who has symptoms that are persisting despite the treatment that you have them on is to make sure that they're using the medication correctly. Incorrect inhaler technique is incredibly common, and an Australian cross-sectional study found that the proportion of patients with COPD who made at least one error in inhaler technique ranged from 50 to 83% depending upon the device that they used. Inhaler technique must be explained and demonstrated regularly. People may have been on a treatment for a very long time, but they will tend to use it incorrectly, and that's particularly the case with the dry powder techniques, where there becomes a tendency to suck in really hard, and that tends to lead to mouth deposition rather than lung deposition. If you have correct technique, it's associated with fewer severe exacerbations, and different devices contribute to incorrect technique, and so it generally would be recommended to minimise the number of different devices prescribed. And this is one of the problems that I have with the generic devices, is that if a pharmacist substitutes the same medication in a different device without demonstrating how to use the new device, it can be associated with significant decreased utilisation of that medication. Non-pharmacologic therapy is equally important to pharmacological therapy in the treatment of COPD. First of those is influenza. We'd recommend an annual influenza vaccination, which decreases COPD exacerbations, doesn't change hospital admissions or mortality. Pneumococcal vaccination. I understand that there have been recent changes to the national immunisation guidelines, but patients with COPD are at increased risk of pneumococcal disease, and the recommendation from the immunisation handbook is that they should receive pneumococcal vaccination at diagnosis and followed by the 23-valent one at 12 months and again 5 years later. That might depend on the severity of the COPD, but is worth further discussion. And zoster vaccination for those aged over 60, it doesn't specifically impact more on people with COPD, but there's potentially the risk factor, particularly with those with exacerbations and the use of prednisolone, whether that increases the risk of developing shingles. Exercise. So exercise may be challenging for people with COPD due to shortness of breath and fatigue, but there is a cohort study of COPD patients that demonstrated reduced mortality with increasing physical activity, and this occurred even in people who were having this levels of physical activity that would be considered below the sort of recommended for their age. I'm not sure how well this projects, but basically this is a graph that looks at sort of physical activity with all-cause mortality in participants with COPD, and showing a dose-response association with total physical activity with mortality risk. Pulmonary rehabilitation, I'm really only going to touch on this, and this will probably be drawn out more in the panel discussion. The aim of pulmonary rehabilitation is to improve the physical and psychological conditions of people with chronic respiratory disease, and it was largely developed from COPD and has been expanded to other chronic respiratory disorders. So it involves patient assessment, supervised exercise training, which is the cornerstone of pulmonary rehabilitation, education, behaviour change, nutritional intervention and psychological support. The benefits actually are comparable to the benefits we see with most of the medications that we prescribe, which is reduction in symptoms of shortness of breath and fatigue, reduction of anxiety and depression, improvement in health-related quality of life, improvement in muscle function and exercise capacity, and reduced exacerbations. If you're looking at the individual components of pulmonary rehabilitation, exercise programs alone do have clear benefits. The benefits of educational psychosocial support without exercise are less well documented, and exercise training programs delivered in patients' homes appear to have similar outcomes and may overcome barriers such as travel and transport, and that's something we'll probably speak about more later in the evening. The improvements in functional exercise capacity and health-related quality of life do begin to decline by 12 months, and maintenance programs may preserve the benefits. And ongoing regular exercise post-pulmonary rehabilitation should also be encouraged to maintain the benefits that have been achieved. Nutrition. Malnutrition is an independent predictor of mortality and healthcare use in COPD, and if you remember the BODE index that we looked at before, you get 1.4 malnutrition, so it's either 0 or 1, so it's quite a significant factor. It occurs in severe disease. Some of the theories are inadequate nutritional intake compared to energy expenditure. Energy intake is reduced due to breathlessness during eating, hyperinflation of the lungs causing pressure on the stomach, and loss of appetite due to drugs. The energy demands are increased due to the work of breathing and metabolic and cost of infections and the systemic inflammation. High calorie nutritional support has beneficial effects, weight, improved exercise tolerance. On the other side of it, obesity is becoming more prevalent. It's also associated with increased dyspnea and fatigue, increased medication use and decreased quality of life, and decreased weight-bearing exercise capacity. However, a slightly elevated BMI is actually associated with reduced mortality risk in severe COPD. So being overweight but not morbidly obese is actually a benefit compared to being underweight with COPD. Treatment of comorbid conditions I'm really not going to go into, but COPD patients have higher prevalence of cardiac disease, stroke, diabetes, depression and anxiety, osteoporosis, reflux, lung cancer and polypharmacy. And some of this relates to smoking because that's associated with COPD, stroke, ischemic heart disease and lung cancer. And it can be seen both ways, because if you have patients with heart failure, so in heart failure, COPD prevalence is estimated to be 10 to 33%, and in COPD patients, 20 to 35% have heart failure. So they're often commonly seen and often present with breathlessness. Oxygen is a bit of a vexed question. A lot of people feel that oxygen will improve how they feel, but oxygen has really only been shown to be of use in COPD in patients who are hypoxic. So long-term oxygen therapy in COPD for greater than 18 hours improves survival and quality of life in those who have a PO2 of less than or equal to 55 or less than or equal to 59 in the presence of pulmonary hypertension, right heart failure or polycythemia. The assessment needs to be done in a stable clinical state, and if it's prescribed during an exacerbation, should be reassessed because more than 50% won't need it long term, and they must have stopped smoking. You can consider ambulatory oxygen if the oxygen desaturation on exertion, but you really need to demonstrate improvement in exercise capacity and or recovery with oxygen. The long-term benefits are unclear. Nocturnal oxygen may be considered in patients who have features suggesting that it is having an impact on their cardiovascular system. So for daytime somnolence, polycythemia and heart failure who don't qualify for long-term oxygen and who desaturate for more than a third of the night. But you do need to exclude obstructive sleep apnea as a cause for the oxygen desaturation, particularly in the overweight group of patients. Interventional treatments are interesting, but really only relevant for a very small minority. Endobronchial valves prevent air from entering the bronchus. That leads to atelectasis of the lobe with the aim of decreasing hyperinflation, improve diaphragm and chest wall mechanics, and decreasing work of breathing. And so on this diagram, you can see the white arrow is pointing to the collapsed lung, and that has led to a rise, which is pointed out with the black arrow, of the diaphragm, which makes the diaphragm in a more physiological position to be able to contract, and so therefore decreases hyperinflation. It might be appropriate for highly selected patients with severe COPD and severe hyperinflation. You need to exclude collateral ventilation, because if you've got collateral ventilation, you can't collapse the lung. There's been a thing in, I think, Sydney, where they used glue to stick up the collateral ventilation, but that's very much experimental. You get improvement in lung function, 6-minute walk distance and symptom score. 25% of those who have it will get a pneumothorax, and that's actually paradoxically one of the ways that you can tell that it might work. If you get a pneumothorax, once the lung re-expands, you tend to get the benefit. But you can get exacerbations of COPD, and those with a lot of airway secretions, having the valves in situ can lead to sort of post-valve obstruction and infection. Lung transplantation. Selected patients with severe COPD may be considered for lung transplantation. It improves quality of life and may have some effect on survival, but it's generally done for symptoms rather than for the survival effect, with the exception of alpha-1 antitrypsin deficiency. So you consider it with progressive symptoms despite maximal treatment, an FEV1 of less than 25%, Bode index of 5 to 6, which indicates around about a 40% 5-year survival, and respiratory failure. There are a lot of contraindications, malignancy, the comorbid conditions, poor compliance and lack of social support, and many COPD patients are not suitable due to those comorbid conditions. Palliative care, palliative care is underutilised in COPD. In Australia, only 18% of COPD patients access any palliative care in the last year of life, despite distressing symptoms of breathlessness, fatigue, depression, anxiety, and insomnia. The barriers to palliative care include a difficulty in prognosticating. People may live a long time with very poor lung function. People also fear that they're being abandoned by their usual physician. There's a perception that palliative care is only for end-of-life care or patients with cancer. Clinicians lack time to discuss palliative care. They may be reluctant to take away hope. They may have insufficient knowledge, and our current palliative care services are already overstretched. Part of the management of the requirement for palliative care is the management of breathlessness, and there are many non-pharmacological treatments that can be used in this condition, including smoking cessation, pulmonary rehabilitation, breathing exercises, such as pursed-lip breathing, activity pacing, so sometimes just explaining that doing something at 80% of capacity rather than 100% allows you to do more. Breathlessness recovery positions and air movement with a handheld fan. Oxygen does not help breathlessness in the absence of hypoxemia, and that's been studied in controlled trials that have compared oxygen to medical air. Pharmacological management, intermediate release morphine is needed, or pre-exertion can decrease dyspnea. Morphine sulfate pentahydrate, modified release, up to 30 milligrams daily. There's a clinical trial that has shown that particular preparation can relieve dyspnea, and that is now PBS listed for the management of dyspnea in patients who are under palliative care. It doesn't need to be palliative care services, but as long as that's the aim of the treatment. Benzodiazepines such as clonazepam drops, there's no clinical trial data, but they may be of benefit in selected patients, bearing in mind that they can cause respiratory depression, so you need to use them cautiously. So overall, management of COPD involves diagnosis, initial assessment with lung function, looking at symptoms, exacerbation history, smoking status in younger patients or those with atypical findings on CT, checking your alpha-1 antitrypsin level, looking at comorbidities, initial management of smoking cessation, vaccination, active lifestyle, and then medication. I haven't really touched on self-management strategies, but obviously that's important. After you've done your initial management, reviewing, looking at the history of exacerbations, whether your medications are achieving their benefits, and adjusting pharmacotherapy and non-pharmacological therapy. Probably gone a bit over time, but I'd be happy to take any questions, or we can move on to the discussion.
So do we have some? No. So don't forget to use the Q&A box there. If you accidentally use the chat box, we'll move them over to the Q&A and we'll answer those as we go along. If you want to get up and have a bit of a stretch, please do that. We probably won't, but we probably need to, but we won't. So we can probably go straight into the case studies, I reckon. Okay, we're going to do that across our panel here of Sally. But Sally, that was an amazing, comprehensive walk through COPD. I think you did extraordinarily well to get that, to give us that overview. Okay, and of course we have Rosie here tonight with us as well, who's a physiotherapist, and we're going to wrap her brains about some things as well. So. I've got 4 cases, which we probably won't get through them all, and these are cases of either my own or that have been given to me by colleagues leading up to this evening. So we'll walk through those. Please use that a Q&A box to ask any questions. This is going to be as interactive as what we can make it, given the circumstances that we're doing this remotely. And we've got some polling questions through there. So please stay in front of your computer so that we can do, you can answer those polling questions. So I'm going to start with the first case. We've got Mr. A, B, C, and D for case 1, 2, 3, and 4. So Mr. A, this was actually one that was given to me by a colleague. So he was sent this discharge summary recently. So his patient, 64 years old, he was recently hospitalised with what was deemed to be an infective exacerbation of COPD. So he was asked to attend for review to his usual general practitioner, which he diligently did about a week later. So he had originally presented to the COVID respiratory clinic with a 2-day history of increasing shortness of breath and cough with brown sputum. When he was there, he apparently looked quite unwell, so they called the ambulance and they gave him some salbutamol there, started him on some prednisolone, and he was transferred to the emergency department, and then he was admitted under the general medical unit. So we know that he's an ex-smoker. He quit 15 years ago, but he'd wrapped up about 30 pack years by then. He also has some gout that was reasonably well controlled and some type 2 diabetes that was controlled, and he's also had some renal stones treated in the past. So these are the investigations that were done in hospital that were listed in that discharge summary. He was found to be afebrile. He did have a chest x-ray, which didn't show any consolidation or collapse. His blood gases, we might get Sally to comment on the blood gases.
Yeah, so firstly, you generally look at the pH. So his pH is 7.4, which is within the normal range. So he's not acidotic. He's also not hyperventilating and become alkalotic, so that's normal. PO2 of 68 for a 64-year-old would be considered a bit low, but it's certainly a safe level, so he doesn't need oxygen, but he is hyperventilating slightly to get to that because his CO2 is just a little bit down. So he's working a little bit harder than you.
Okay, yeah, which fits in with sort of his breathlessness.
With respiratory illness.
Yeah. And his inflammatory markers were up a little bit, his white cell count was up a bit, and it had come down by the time he was discharged a few days later. And he didn't sort of have any signs or symptoms of being in heart failure at all. He was deemed to be COVID negative, because we haven't actually had that much COVID. And he had a sputum culture whilst an inpatient as well, which was negative too. Now, this is something new to me. He had a SMART COP score of 2. Now, that sounds like something that gets done in hospitals. Is it a pneumonia score?
The SMART COP is a pneumonia score, and a score of 2 would be a low risk of dying from pneumonia, which he actually didn't have because he didn't have
his chest
consolidation.
His chest and he was afebrile.
Well, you can be afebrile, but certainly pneumonia is diagnosed on chest X-ray, unlike COPD, and you would need consolidation to do that.
So he was treated with initially, understandably probably, with some intravenous antibiotics, and then he was transferred over onto oral antibiotics and Kefalex, and because he is penicillin allergic apparently. He was treated with the usual salbutamol and prednisolone when he was an inpatient as well. So that's what we know from the discharge summary. Okay. So his discharge therapy was, I think he was in hospital, I haven't written it up there, but I think he was there for about 3 days. Okay. So he was discharged on Kefalexin to complete that course, a weaning dose of prednisolone, some salbutamol with a space of 4 puffs 4 times a day as needed, some ipratropium as well, and his usual drugs were continued, his ones for his diabetes and his gout therapy. So he came to see his usual GP a week later. He was afebrile, his breathlessness had improved, because remember that was his presenting symptom, and he feels really well now. So where to from here? So we're going to go,
Before we go on, I just think on the basis of looking at the prednisolone, The evidence for use of prednisolone in COPD, there's certainly no good evidence that long-term prednisolone produces any benefit in COPD and is associated with significant comorbidities, in particular osteoporosis and increased risk of diabetes. But having a look at his discharge prednisolone, that's also not something that we would recommend in COPD.
I'm going to ask you about that.
The evidence in COPD is that short courses of prednisolone for exacerbations do decrease the duration of the exacerbation and improve breathlessness. But generally, the doses that have recommended are somewhere between 30 and 50 milligrams for 3 to 5 days without the need to wean.
And this is one of the things I want to draw out afterwards, and that's why I emphasised that he was actually admitted under a gen med unit. So this is not consistent with even with our COPDS guidelines and whatever, so we'll go into that. Okay, so get your fingers ready for a polling question. Okay, so where to from here? The hospital actually told him he had pneumonia. His discharge summary tells us that he had an acute exacerbation of COPD. This particular gentleman, Mr. A, had never even heard of that terminology. Okay, so where to from here? Do you go to the health pathways? Okay, yes, and I'd like you to, we've got 5 different responses there for the polling question. So would you go to the health pathways to find out about COPD? Do you do that all the time? Or do you do it sometimes for COPD? Or you've never accessed the health pathways? Or you don't even know about them, or you maybe know about them, but you've accessed them for other conditions, or you actually have no idea what I am talking about. So please put in your responses now, and we'll see those come up, and I think this will be quite interesting to see. Okay, do your polling question. Okay, I've got some helpers here on the side here who are monitoring all this, and they will tell me, or they will show up the responses when you've all hit your keys to answer that. Okay, now I can't see it up on the big screen, so I'm going to have to look really closely here. Okay, so I'm not surprised. Oh, you've got them on. It's all right, I can see them on here. So, and I think everyone else can see them as well, maybe. Yeah. So there's not somebody who does it all the time. Some people have done it sometimes. You've never accessed them for COPD, and I must admit, I haven't actually either. But I know what they're saying. And you might have accessed them for other conditions, and some of you have actually no idea what we're talking about. So, but there will be some information at the end about accessing the Health Pathways portal and how to get a username and a password to do that. So, okay. But we're going to go to another polling question, and I love to hear what you say about this because this really interests me. So, should we be confirming this diagnosis of COPD? Now, the hospital told me he had pneumonia. Okay, but he's come to see you a week later. He feels quite well. He's no longer breathless, so maybe you don't even need to do anything more. He doesn't have COPD. Or do you just accept that hospital diagnosis and code in your own electronic health record COPD, see discharge summary, the hospital said you had acute exacerbation. Do you do another chest x-ray? Okay. Or would you like to confirm the diagnosis of COPD with spirometry, or would you like to screen for a diagnosed COPD with microspirometry? And there could be 1 or 2 correct answers there. So, but I really love to see what your responses are. So please answer now. How are we going there? We're getting there? Okay, are we ready to share our answers? Yes, we are. Okay. Sally, I think they must have all listened to you really, really, really well. Okay.
Sorry,
because,
it's a personal beef of mine.
yeah, they listened. Okay.
Yeah.
The majority of people did actually say they wanted to confirm that diagnosis with COPD was spirometry. But in fact, you showed the Lane study, which was based in Melbourne, 41 general practices, I know that study really well, and showed that about a third of patients who were coded or being treated for COPD, when they actually went out and did their lung function, actually didn't meet the criteria for COPD. And we know that a large majority of the classification of COPD has actually come from when the patient has been gone to hospital with a diagnosed COPD and then not been confirmed.
Yes.
Yeah.
Yeah, and I think the hospital systems, particularly busy general medical units, the people who are running the day-to-day treatment of these people are often very, very junior doctors. So they're sort of interns, first-year RMOs, and yes, they should all remember everything about every condition from medical school, but practically it's not. And if somebody says this person's got COPD, they put it down and they run with it. So I'd, take discharge summaries with a bit of a grain of salt.
And I think that's our message to you, is that we're out there in general practice. This can be our responsibility, to actually confirm that diagnosis. And confirming the diagnosis of COPD is actually not that hard, is it?
And actually confirming the diagnosis in a period of stability is much more suitable than doing sort of in-hospital spirometry on a patient who might be acutely unwell with a respiratory infection, who would then have difficulty doing the test and would potentially make it more distressing to do.
Yes.
The diagnosis is probably best made in a period of clinical stability.
Yes. Now, when that patient is stable, if it's difficult to do spirometry, and accessing spirometry in general practice is a little bit tricky at times, it's probably quite reasonable to actually case find with a microspirometer, such as the COPD-6 or a PICO-6 device. So there is more information about that on the Lung Foundation website. Lots of resources there about that as well.
I think the other point I would make is that particularly in Adelaide now, there are other avenues for getting spirometry. I mean, I know a lot of general practices do have it, but spirometry is available through public hospitals. It's available through private respiratory physicians. I think the gap to get spirometry is less than the gap to get a chest X-ray done. And a lot of places, if there's financial difficulties, and that's mentioned, will do spirometry with no out-of-pocket charge to patients. So I think there's a perception that it's hard to get to, but it is actually more available now.
Although we do have to consider our rural, remote and regional place people and certainly if you're using a microspirometer device, a COPD-6 or a PICO-6, if that is abnormal, then these patients do need to go on to have proper spirometry, pre and post bronchodilator spirometry. So not using the microspirometer to make the diagnosis, but just to screen for
it. I think in general practice, case finding and doing the PICO-6 or COPD-6 on any ex-smoker who's got a 10 to 15 pack year smoking history will pick up those who potentially have airflow limitation at a time when even doing on all your current smokers, because actually demonstrating abnormal lung function is a powerful tool for getting people to quit.
Yeah, absolutely. And as I said, on the Lung Foundation website, there's videos, there's other resources. Okay. Managing, if we assume that this gentleman did have a COPD exacerbation, what do we do with him when we see him the week later? And the Lung Foundation, fortunately, has helped us with that as well. So last year, I think we developed this document, and it was really to help also to guide those junior doctors in the hospital, but we also wanted something in there about the ongoing care in the primary care setting. So these are the sorts of things that we think should happen for a patient who has been discharged from hospital with a COPD exacerbation. So I think you've emphasised before that we do, you know, the number one thing for these patients is they need to give up smoking. Now this patient is already an ex-smoker, but we need to make sure that he doesn't start smoking again, although the chance of him after 15 years is pretty slim. Okay. We need to make sure that these patients are on appropriate medication. They need an action plan. You've talked about the vaccinations, immunisations, influenza, pneumonia. We're going to talk about pulmonary rehab. This particular patient obviously wouldn't need oxygen therapy, but you've highlighted that as well, and whether there's other referral pathways that we need to implement as well. So, and referring to that stepwise management of stable COPD, the document that you showed before about how to step up therapy if need be, and those non-pharmacological therapies. Okay. So we do have Australian-based guidelines. Yes, that we have the big document, the COPDX plan, which is about 160 pages that no one in their right mind is going to ever read. But we do have the COPD concise guide, which was originally developed for primary care, but we found that it was quite useful even in hospitals because it's easy to read. It's only about 40 pages and you can read it in an hour. So that is on the COPDX website, and it gives us everything we need to know for us. Maybe not you, but for us, that we need to know managing COPD. Okay, and then there are some other clinical resources as well, such as the action plans. You spoke about the what I call the TikTok graph, where you've got the medications, and so that you don't end up on two LAMAs or two LABAs, or
and one of these which we can't really show you their face, so as to speak. The one that's got the inhalers on it is an invaluable tool for both COPD and asthma, because you will all, I'm sure, have seen multiple. I
don't know whether it's not going to show up, but it's on the back of the stepwise.
But it's very good. So when people say I've had all the puffers, you can point it out, or they say I was on this puffer. But I think that those are very useful resources.
Yeah. And then in regard to exacerbation management, there is a really clear and succinct guide as to management of exacerbations, and as I said, the action plan as well that these patients will benefit from. Now, those guidelines also recommend that a patient who has been admitted to hospital with an exacerbation would possibly benefit from pulmonary rehab. So we have a pulmonary rehab expert here. So I'm going to ask Laura to tell us about, not Laura, it was going to be Laura, but we've got Rosie now who's come in at the last moment. So thank you, Rosie. And would you like to tell us what is pulmonary rehab, what does it involve, and what are the sort of outcomes that you'd expect for pulmonary rehab? What are the benefits to patients for pulmonary rehab?
So I'll speak to my experience. I work down in the Southern Adelaide Health Network, so out of Flinders, and we run two programs based at Flinders, and then the one I work in is down at Noarlunga. But I feel confident in saying that my experiences would reflect that of my colleagues through Carl and Narlan as well. And most pulmonary rehab courses would involve typically an 8-week course, and patients would come in twice a week for an hour of exercise and then an hour of education as well. And once we get a referral, we'll triage that. So certainly when we get referrals, it's particularly useful to have as much information as we can have so that we can establish suitability at that point, and then follow up any investigations that need to happen before we actually get patients into clinic. So particularly if we're waiting echo results or ECG results or other studies, it can be really helpful for us just to pop that patient on hold or follow up information with the GPs before getting them into clinic. And then we would bring them into clinic, and typically this does vary a little bit between programs, but that might involve meeting with the physio and then potentially having a respiratory nurse, having a look at them, trying to check their technique with medications and having a look at some of the other aspects of care. But certainly from a physio perspective, we would be just doing a bit of a meet and greet. And sometimes I think the most important thing is actually just introducing them to exercise. And I think Sally touched on exercise is such a frightening concept, and trying to normalise breathlessness and language like I'll get breathless if I run 5Ks, and that's perfectly safe and okay. But if you walk 100 metres, you might start to get breathless. That's okay as well. It's just about managing that, knowing your limitations, knowing how to recover. And I think certainly when talking and sort of dropping the big word of exercise to these patients, normalising breathlessness and telling them that breathlessness is indeed safe as long as it's controlled, can really help with uptake and engagement.
Because they get really
scared.
They get really scared of the breathlessness, don't they? And they've often restricted their activities to manage the breathlessness. But we want them to just challenge themselves a bit more, don't we?
Absolutely.
And they've got experts like you. They've got nurses and physios there monitoring them during that time.
And I think, as Kara said, it's that vicious cycle of breathlessness, doing less, deconditioning, and being able to do less as a result of that. Yet we know that physical activity is such a benefit to these patients.
That's one thing I always, when I'm trying to encourage people to exercise or to pulmonary rehab, sort of give the example that if you don't use it, you lose it. And if anybody goes to bed for 6 weeks and doesn't move, then they're going to feel weak and wobbly. So try to encourage those first steps.
So Rosie, is it only patients who've had an exacerbation or who've been in hospital who can access pulmonary rehab?
I think we know from the guidelines that every patient should be offered pulmonary rehab after an exacerbation, and certainly they are prioritised.
Whether they're hospitalised or not hospitalised.
Absolutely. And certainly they are prioritised in terms of the speed of access to the service, but I think every patient will benefit from pulmonary rehab at some course through their disease journey. But I think also we know that the benefits only last 12 months on average, and they start to drop off after that point. There's discussion about if they can continue to engage in exercise, whether the benefits continue. But I think it's very reasonable to re-refer, because not only has their disease maybe progressed or changed, but patients forget things, or they stop to engage with some of the interventions that they found quite helpful.
I'm going to ask about Carlin in a minute, but while we've got Rosie here, what about those, what are you doing with COVID times at the moment? I know what you're doing. But yeah, tell us about home-based pulmonary rehab. Yeah.
So about, probably in the last 5 years, research has come out of Melbourne particularly, looking at home-based rehab, and I think Sally touched on that as well. And there is some equivocal outcomes, but I think the difficult thing is selecting the right patient. So certainly patients that are desaturating significantly, and particularly if they're not feeling the effects of the desaturation and can't stop themselves and have that safety net, there is certainly a cohort that really does need to be supervised for exercise, at least until they can start to learn some strategies to put some safety boundaries in. But we certainly did start to do some home-based pulmonary rehab over COVID times. We've started to move back towards centre-based now that restrictions have eased, but there's sort of a bit of a contingency plan to move back to home-based rehab depending on what happens with COVID.
I find one of the issues is, patients go off and do pulmonary rehab and they just think, and you touched on this, they just think, okay, I'll go for 8 weeks and that's it. And the maintenance pulmonary rehab, the maintenance exercise doesn't happen. So I think that we as GPs who are seeing these patients quite regularly need to be asking the whole time about physical activity levels, don't we? Are you going out there? You've learnt these lessons from pulmonary rehab, you know the value of exercise, and sort of keep encouraging them to do that and make that happen, either by referring on to maybe exercise physiologists and just to appropriate gyms or whatever. And I know you try and do that, encourage that through the pulmonary rehab program, it seems to fall down a bit.
Well, it does, and it's one thing to have that conversation and key something up, but it's another thing for that patient to actually take the plunge and attend, an unfamiliar environment or a new place. So I think it's particularly helpful if you can take note of what the plan was at the end of pulmonary rehab, and try and follow up and see if patients have engaged.
I suppose one of the other difficulties we have is that you need to go twice a day. Twice a week? What do you do with people who are working?
Yes.
Like, they need to then.
I think that's also where, although the sort of studies suggest that everybody with COPD can benefit, once again, most of the studies have been done on people with moderate to severe COPD. So, certainly I see a cohort of people with perhaps milder lung disease who are self-motivated and who are attending a gym 2 or 3 times a week. And for them, attending a pulmonary rehabilitation course at that time point would probably not be suitable. So I think it's looking at the exercise, and I think people who really benefit from the pulmonary rehab are those who are in that lower group of exercise or recovering from an exacerbation, or who particularly have anxiety and need that sort of peer support to be able to do that. The others sometimes need encouraging to not do quite as much.
So from you're associated with Central Adelaide Local Health Network. How do my colleagues refer into your service?
Well, they could.
To pulmonary rehab.
So there's direct referral for pulmonary rehab through Carlin. They might you knowing the state of any of the search engines for any of the hospital programs, it might be hard to find, but an assessment is similar. So the more information that can be provided, the better. Programs were temporarily on hold through COVID, but the Royal Adelaide Carlin service is still running through Hampstead, and that's back up and running, I believe, at the moment. Certainly some of our physios were doing Zoom classes for their rehab ones, so that's sort of somewhat interesting. It also gives you an insight if you're into the patient's home as well, so that can be helpful from an education point of view, because you can actually see what inhalers they've got sitting on the cupboard behind. So I think that's been helpful.
That's where maybe a home medicines review might be helpful as well.
Well, I actually think that the home program would be excellent, even if it's as an introduction to get people involved. So I've had a number of people who particularly those who are carers of partners who are unwell. If you're caring for a partner who's got dementia, you can't leave them for 2 hours twice a week for 8 weeks because it's not safe. And so some of those people would benefit from having that home service.
And we should mention the Lung Foundation videos on their website. There's about a dozen of them now for exercise.
And certainly the study design that came out of Melbourne, it did involve a home visit initially by a clinician to set them up with the program, and then telephone follow-up. And they use the Lung Foundation Living with COPD guide to replace the exercise component.
But there's actually some videos now that they've developed through a lot more through the COVID time to that those patients can access for exercise. There's one about being in the kitchen and.
I think home rehab would be a really exciting area to watch.
And certainly in other aspects of rehabilitation, there are travelling physios who will go and do series of at the moment it's probably a little bit more post joint replacements and things like that, but to actually have someone on the road to do that one-on-one education.
And slightly different, I'll speak to our HERO program just briefly, which is the home respiratory rehab sort of post-acute exacerbation. Certainly in my experience, going out into a patient's home is invaluable because they present very differently in clinic. You're seeing everything that's going on, you're seeing where things are really pulling through the cracks, but patients just are a lot more relaxed in their environment. And it is a real privilege to go out there and be able to get that information.
Do you have any questions there?
Just the one question about macrolides and how they fit into COPD management.
Okay, well maybe we can move away from pulmonary rehab for a moment and we'll throw that to Sally, because you didn't mention macrolides at all.
No, because it's still an area of really, one of the things with macrolides is that they do have the anti-inflammatory action, and in certain disorders that's been really something that's brought to the forefront. So in cystic fibrosis, in those colonised with Pseudomonas, the use of azithromycin 3 times a week decreases exacerbations. In asthma, there's an Australian study that showed the use of azithromycin can decrease exacerbations, although it's not PBS listed for that indication. The data in COPD is a little bit more less robust. There are some studies that suggest it does have the anti-inflammatory effect. The downside is that the one that's mainly studied is azithromycin, which is not available on PBS for any indication, apart from sort of any indication for long-term use for its anti-inflammatory effect. And the other thing that we always worry about is the problem of antibiotic resistance and also colonisation and infection with more resistant organisms. So I think at the moment it's really a work in progress. We probably need more data. There certainly are some individuals, particularly those with recurrent exacerbations, that you may try a trial of antibiotics, whether that is a macrolide or whether it's something like doxycycline, depending upon their airway colonising organism, is somewhat, that's not really proven as to which way you should go. And so now I certainly have a number of people who I have had trials of using antibiotics in, sometimes successfully and sometimes not. But I think this also comes back to what I said earlier about airway colonisation versus exacerbation. And so some people with chronic bronchitis will have cough and sputum production all the time related to the sort of inflammatory nature of that disease. And there may not be anything that will stop them from doing it. So finding a bacteria doesn't necessarily imply infection. And sometimes it can be a matter of managing expectations and actually saying, unfortunately, as part of your COPD, you have cough and sputum production, which is part of the underlying inflammation, and we don't actually have a medication that is going to stop that from being there. And long-term antibiotics may not be helpful, because the real danger in that situation, if you clear out the sort of normal respiratory flora, is you open it up for bacteria, particularly Pseudomonas, which can then make life very difficult in the chronic bronchitic group.
Before I move away from Mr. A, there's just a couple of other things I'd like to ask you. I mean, I commented about the prednisolone and that regime, but I found it quite interesting that he was actually discharged on a short-acting beta agonist and a short-acting muscarinic antagonist.
I think normally you choose one
or the other, yeah. And so we're seeing this man now a week after he came out of hospital. We don't quite know if he's got COPD because we haven't done the spirometry yet. Would it be fair enough to just continuing him on sort of an as-needed short-acting bronchodilator, whether we choose a SABA or
I think in this man, quite honestly, it seems like he's probably just had a nasty respiratory bronchitis. He may have underlying COPD. We need to do that. Probably the safest is to use something like a short-acting beta agonist. Short-acting muscarinics have that slight increase in cardiovascular risk, and he's got diabetes.
All the more reason for limiting that prednisolone as well.
And that's the other reason to actually make a diagnosis, because one of the problems is that we get underdiagnosis of COPD, so people miss out on the education and benefits of the pulmonary rehab and other forms of treatment, and then you get overdiagnosis and people end up on a lot of inhaled medications that they don't necessarily need. Probably as a pragmatic thing, you'd perhaps continue him on his short-acting beta agonist, which it doesn't sound like he's needing.
No,
and
at
some point in the next period of time, do some spirometry. Now we can again.
Or he may only be breathless because he's not actually doing anything as well, because that can be a bit of an issue with these patients as well, is that they do become quite sedentary, and it's not until they're pushed a little bit more that we discover he's breathless. So if we do confirm that diagnosis of COPD, and he tells us that when he climbs up the hill a little bit, he gets breathless, would you be doing the as-needed short-acting, or do you think there's benefit then in changing him to what stage do you shift him over to that every day,
It will
long
depend.
acting.
In him, if he's had exacerbation and minimal symptoms, it will probably depend a little bit on what you found on the spirometry. If he had very mild airflow obstruction, a single exacerbation or a single episode of bronchitis, then is he the sort of person who is going to take a medication every day ongoing? And if he's not, then maybe doing a short acting as needed is the better approach. If, on the other hand, you actually demonstrate he's got moderate airflow obstruction, he's had an exacerbation, you maybe push him a little bit harder and find that he doesn't mow the lawn anymore because he gets breathless. In that case, trialling the a long-acting muscarinic or a long-acting beta agonist might be worthwhile. However, the major reason for using particularly the long-acting muscarinic is the actual decrease in exacerbations. A lot of people only get a moderate improvement in the shortness of breath from the medications, and so the fact that you don't get an improvement in breathlessness may not be a reason to stop a medication if your main reason for starting was to prevent exacerbations. Now, in this man, you might not, because it's only a single one, but if you're making a decision on someone who is a frequent exacerbator, the main reason to treat is the exacerbations, not the symptom benefits.
Yes, but trying to convince him that he's going to benefit from that might be a little bit challenging.
It can be, but sometimes if you just explain, look, last year you needed 6 lots of antibiotics, let's see how many you need this year while you're on the treatment.
And that's why I think it's useful to go back through the medical record and see whether he's actually had events which may well have been missed exacerbations, because we know that has been a problem when they've looked at electronic records and found that people have had 2 or 3 exacerbations in the past before they've actually got their diagnosis. Okay, let's we've got half an hour, so let's go to Mrs. B, our second case. She's a 68-year-old lovely Scottish allied health worker who treks all over the world, and until recently. So she's got stable, well-controlled, long-standing asthma since teenage years, with significant airflow limitations shown on spirometry. So she was a smoker in the past, but she stopped many years ago now, but she had racked up about 25 pack years. She's a non-drinker, she's vegetarian, and she remains very active, goes hiking. She just has some osteopenia, and that Anglo-Saxon skin has made her prone to BCCs and SCCs. And in 2001, she required frequent courses of prednisolone. She had been under the care of a respiratory physician for a number of years, until about 12 years ago. She's deemed to be non-atopic. In 2016, she was referred off for airway clearance. This is my patient. I've actually seen her quite regularly since I inherited her in 2001, and I do CAT scores on her because I like the COPD assessment test. Now, it might be more relevant that she has an asthma control test done, but we get a lot of benefit out of the CAT score. It's horses for courses. Her immunisations are up to date. Okay, now, airway clearance. What is that?
Yes, well, where to start? Chest physio, you might have probably the first thing people think of is tipping people or a little bit of pitter-patter, which certainly has a role, certainly in the acute setting, ICU setting, where patients can't do anything active, and in a paediatric population. But just briefly, I know we've got people with varying backgrounds. There's 2 sides, I suppose, to clearing your lungs. If you cough, you clear any mucus that's sitting up in your large airways, your trachea or large bronchi. But the mucus itself is produced out in the bases or peripheries of your lungs in the small airways. And we've got what we call a mucoaxillary escalator, or small hairs that beat that sputum to a point. You can cough it up. And the role of sputum being produced daily is to catch any dust, pollen infections, and bring it up and out to keep our lungs clear of infection. And of course, what can happen in patients with COPD or bronchiectasis due to the smoking, there's a loss of integrity to the airways, or the cilia don't necessarily beat effectively, and we get a picture of sputum retention. And certainly in this lady with asthma, you certainly can, it's not as common as, say, a patient with bronchiectasis or COPD, but you can certainly get a hypersecretory mucosa as well. And I suppose some of the indications for referring to airway clearance, you might have a patient that is infecting frequently, or needing multiple courses of antibiotics when they do infect to actually clear it up. They've got a chronic cough that's cleared when they do eventually clear some mucus, waking up at night, or first thing in the morning because of the pooling of secretions, they'll wake up with a bit of a cough. And the goals of treatment would be to initially dislodge some of that peripheral mucus. And some of the typical techniques you might see in the community is PEP devices, which stands for positive expiratory pressure. And Kerry's got a beautiful picture down in the bottom left corner of an air beaker. And you may have heard of acapellas or flutter devices, or some of your patients might have come in with these devices. And the main way these work is by exhaling into them, and you get a positive expiratory back pressure on your airways. Splints the airways open, utilises collateral ventilation to get air in behind the mucus, so that we have half a chance of moving it. And then we might use techniques like huffing, for example, to bring that mucus to a point that a patient can easily and effectively expectorate their mucus load. Did you have a question?
Yeah. And what's this thing? Yeah.
That on the back of the aerobeaker, that's a saline a nebulizer attachment. So you can attach, depending on the patient, you might attach saline to thin the mucus out. Obviously, if you've got quite sticky mucus, we want it to be the texture that is easier to expectorate. So you can thin it out using saline. Certainly, we can put in inhaled antibiotics or salty water to try and thin out the mucus, again, more than a typical hypertonic saline. Hypertonic saline, yes, sorry. Yep. But typically for the care of a COPD patient, the most you would see is a salty saline solution, occasionally maybe an inhaled antibiotic, but it would be rare in COPD, and typically just for a short period of time if they had a specific bacteria, in my experience. I don't know if you want to add anything to that.
Yeah, look, I think in COPD it would be more common to use nebulized saline. One of the things you do need to be a little cautious with the hypertonic saline is that it can provoke bronchospasm, and so it's not something that we would generally do in those who have a history
as well. Hypertonic saline.
Some pharmacies will make it up, and it's because it's not considered a drug as such. So there's a few companies that make it, but and really, I guess the other thing is, if you're looking at evidence base, there's not a lot of evidence base for hypertonic saline in COPD. The evidence base is really confined to cystic fibrosis. Even non-cystic fibrosis, bronchiectasis, there's not a lot of good evidence for hypertonic saline. There's actually an Australian invention, hypertonic saline.
Okay.
Yep.
But it's likely that there will be some patients who have these PEP devices, the acapellas and the aerobeakers and whatever. So, and that was certainly something that I only learned about a few years ago. So
I will just, if it's okay, just speak to, I think the key with airway clearance is using it consistently and prophylactically. There's no point in having it in the cupboard, getting a chest infection and then picking it up to clear your mucus. The whole point is to clear the peripheral secretions so that they're not sitting around making a patient more prone to infections. And certainly a selling point from a symptom perspective, if we can control their cough, they're more likely to be compliant with their clearance.
The other
as well.
selling point I find, because a lot of these, you're not going to stop people having the hypersecretory state, but if you can actually say, look, if you use this, in a lot of people, if you use this, it means you can clear your mucus at a time that's convenient to you and then not be coughing the rest of the day. And that can work quite well.
Especially in these COVID times when coughing out in public, you feel a bit like a leper.
Do you ever use bubble PEP?
Yes, quite a lot, just initially as a trial to see if PEP's going to be a suitable intervention, really. But there are some patients that we try them in bubble PEP, and because of just the long expiration that you can achieve with water, the sort of a mechanical device, we keep them on it long term because they just have a better outcome, especially those with the poor FEV1 seem to gravitate towards the others.
My only advice on that situation is to make sure you have a patient that actually is fastidious about changing the water, because sometimes that can be a bit of a downside.
Absolutely. But true of all, just on that, if you do have a patient with any of these devices, they should be washing them and then sterilising them weekly as well, so that they're not becoming petri dishes.
And this is where, seeing them to a respiratory physiotherapist is actually really useful. I mean, this isn't something that I would take on board myself to do. I would be engaging a respiratory physio.
And particularly a respiratory physio, I often liken it to, you wouldn't send someone to back pain to see me, because I wouldn't be very helpful. It is a niche area that does take some experience and training really to get effective outcomes.
And that's, I think, if you're wanting respiratory physio, you need to be very specific about the question that you're asking. I know that the Carlin physios will see people for sputum clearance if it seems to be an appropriate one.
And certainly we can send down to Salon physios through the intermediate care services.
Yes, and Nowlan Intermediate Care has a service as well.
And there's also a number of private respiratory physios, but it needs to be specific because, and it's a fairly small pool of people.
Excellent. Okay, so going back to Mrs. B, she's a very compliant patient. She has lung function every year, and it's remained sort of relatively stable over the years, and they're actually done at a respiratory function unit, so we get a lot more information. So let's just have a look at her lung function. This is the one from January in 2009, and I think you agree, Sally, that does show that she's got a severe obstructive pattern there with the acute bronchodilated response, because she does have this history of asthma from adolescence or childhood. And the comment from the person who interpreted this was that she's got some hyperinflation with gas trapping and some reduced gas transfer. Does she have COPD?
This is where it gets technical and tricky, because she does have COPD, because her post-bronchodilator FEV1 to FEC is less than 0.7 and her FEV1 is less than 80%. So that is the definition of COPD. She
has asthma as well.
But she has not as well. Okay, this is also where it becomes tricky, and this is where it becomes somewhat semantics, and this is why the more information you put on your lung function, the better the interpretation. So this in isolation, without knowing her history, could either be COPD with an acute bronchodilator response, or it could be combined COPD and asthma. So that's where it does become tricky. The thing that's really important to recognise is that these people don't meet our clinical trial criteria, and so don't fit the nice neat boxes. In a person such as this lady, one of the things that this would do, if I was looking after her, is it would change the order of inhalers that I prescribed for her if she wasn't on any to start with.
Right. Now, why did it get reported that she has hyperinflation?
You haven't got,
on there.
You haven't got the lung
bits.
volumes. Now, the thing that you would look at for hyperinflation is her total lung capacity, which is 110%. But the gas trapping, you need your residual volume,
which was not on there. And what about the reduced gas transfer?
So her DLCO is 51%. Now, part of that might be her airflow obstruction. So there's usually what's called a KCO, which takes into consideration the lung volumes, because if you're not the DLCO relies on a small amount of carbon monoxide being absorbed into the lungs, actually not thrown into the lungs, onto the red blood cells passing through the lungs. So it's measurement of the efficiency of transfer of gas from the air into the lungs. So anything that affects that process will affect the amount of that gas that can be absorbed. So if you have decreased lung parenchyma, which she probably would, I guess, just looking at this in the setting, would be that one of the causes of this would be that she's got emphysema. So she has decreased alveoli available for gas exchange, and that decreases her gas transfer. However, in the presence of severe airflow obstruction, if the airways are very narrow, you may not actually be ventilating parts of the lungs effectively, so it can actually reduce the gas transfer measurement, but it doesn't reduce what's called the KCO. So you'll see an adjustment in that situation. So sometimes people with severe airflow obstruction, just because of asthma, will have a reduced gas transfer, but not normally to this level. So if it was 75%, which is below normal, it still would. So asthma is an airway, a pure airway disease, so you should not see a decreased gas transfer in that setting, but a mildly one may be sort of artificially seen because of the severity of the airflow obstruction.
Yeah. So doing those full lung function tests like you do in the laboratory gives you a lot more information.
It does, because the FEV1 FVC are really just looking at airflow through the airways. It's a measurement of airway calibre and flow rate. The lung volumes are looking at, as it says, at the lung, the actual size of the lungs, and looking at the degree of emptying of the lungs with the residual volume. And the DLCO is a measurement of the lung parenchyma and also the pulmonary vasculature. So I think, and also it's decreased by anemia, because if you don't have red cells to pick up the carbon monoxide, you get it artificially low. So all of those are corrected for.
And they usually give you a haemoglobin result on that full lung function test, don't they? Okay, so she comes for her scheduled review, which was just recently, and she's been well. She's had no flare-ups, she doesn't have any nocturnal symptoms, she's got no limitation in her activity level, she's still walking daily. In fact, I rang her last night to get consent to do this, and she was out walking the dog. She's not overweight. She has a CAT score of 13, which I won't challenge you with that, but that's sort of like a, you know, if there's some significant impact on her with that. Should I have done an asthma control test score, but I would think that she'd actually probably score quite well on her ACT. Her MMRC, you spoke about MMRC, she's one, she gets short of breath when she has to walk up a bit of a hill. And her medications that she has been on for many years now are some fluticasone and salmeterol, the 125/25 2 puffs twice a day, which gives her like 500 micrograms of fluticasone propionate a day. Umeclidinium via the Ellipta device was introduced a few years ago now, and salbutamol as needed, which she doesn't really need, and we're protecting her bones with some vitamin D and calcium at the moment. So that's her lung function that was done just recently, which is sort of fairly...
so the sort of scoop that you're seeing reflects the airflow obstruction curve. And they're separated, which suggests a bronchodilator response.
So this was the actual figures for that lung function. So she didn't have the full PFTs this time, but once again we're seeing that FEV1 down at 65% and that ratio down at 0.53, similar to what we've seen before. But should she have had, I mean, how often should someone like that maybe have those full lung function tests done, and the lung volumes and the gas transfer and all that? I mean,
well, I don't think there's a right answer to that. I mean, some people will do them every 3 months, which I think is a bit excessive. You know, some people, I think the short answer is at least once.
Okay. At least once. Okay.
For your diagnosis.
Yeah.
I guess asthma is always interesting because you may have normal lung function, or you may have a picture that looks purely like COPD, because acute bronchodilator response isn't always seen. So if you're suspicious that someone has asthma, you might repeat them a little bit more often. I think it depends. You know, I think you should repeat lung function if there's a significant change in symptoms. If there doesn't appear to be the response that you have thought there would be to treatment. Now, I think if you've got somebody who you've already proven has very severe COPD, for example, then doing lung function can be distressing, and you might argue in that situation, if you already know it's very severe, that you're not going to change management based on it. And if they're not somebody who you would be considering for lung transplant or endobronchial valves or anything sort of out of the ordinary, then it may be that you accept that it's severe COPD and don't necessarily repeat it. I mean, I think
this would be classified as sort of mild to moderate.
Yeah, I mean, another thing I think is interesting with this COPD, but she's also still got a significant component of asthma. So I'd be interested in, on my other hat, I'd be interested in her eosinophils and IgE at this point.
I've looked at those. Eosinophils aren't actually up. No, they're not. I didn't put those in here, but I actually had a quick look the other day, and that's why I commented on the skin fit testing as well, being negative, because I went back and looked at all that and her IgE. But not absolutely necessary to do the whole sort of PFTs every year, but at least.
Well, once again, it would depend. It would depend. So if you have somebody who has asthma, maybe they have smoked a little bit, you might do full lung function. If it's demonstrated completely normal gas transfer, then you might not necessarily repeat it if you're following asthma.
Who's got that reduced gas transfer.
If you've got someone that's got a reduced gas transfer, then you're probably doing that once a year or once every couple of years to just get an idea of the trend would be potentially helpful.
I don't have to feel guilty for not doing it this time.
No, I don't think she necessarily needs it every year, because once again it comes down to what's her diagnosis and is doing this test going to change your management. So if she came along 1 year and said, actually, I'm a lot more short of breath than I was before, you might do your spirometry. If it's no different, then you go, well, maybe we need to recheck and see if you do have worse hyperinflation or your gas transfer's dropped. One of the reasons for a drop in gas transfer is actually the development of sort of cardiac disease and pulmonary hypertension. So if you suddenly saw a drop in the gas transfer in someone with COPD, then you might go, actually, have they developed secondary pulmonary hypertension, and take you down a different way of investigating.
But she's been actually quite stable as well,
just in general.
So that's good. Okay. So what we did, we obviously reviewed her asthma action plan or a COPD action plan. She's got asthma COPD overlap, so we can courses which one you want to use. We checked her inhaler technique, talked to her, her influenza's up to date, and we talked about pneumococcal vaccination, which she has had in the past according to the previous guidelines, but of course the guidelines did change. So these were things I was going to discuss with you, but we discussed them as we've gone along about how often to do the lung function testing and whether it should be the full pulmonary function tests. She has been reasonably stable. The FEV1 has reduced over the last 5 years from the 2.06 to 1.73. Probably a little bit more than you expect with age-related loss.
I think so. I'd need to look at the percentages. It's always hard to...
Well, her percentages actually stayed much the same. They were about 65% all the way along.
So she may be tracking at 65%.
Yeah. So, and then the question on my mind was, should I offer her now the according to the immunisation handbook, the 13-valent pneumococcal vaccine. She's been fully immunised to the 23-valent polysaccharide pneumococcal vaccine, but our guidelines immunisation handbook would say that she should be offered the private one, but of course that's not funded on the National Immunisation Program until she's 70. She's not quite 70 yet, so she's in a few years' time.
That's always a tricky one, depending on the severity. And I guess the other thing I'd just like to say is before I alluded to the fact that I would change the order of puffers. And the main reason for that is if you've got somebody who genuinely has asthma, the primary pathology in that is airflow inflammation, so airway inflammation. And the first treatment that you should use in asthma is an inhaled steroid. While in COPD, probably the last treatment you should be adding is an inhaled steroid. And so that's where the differentiation between asthma and COPD is important. And also, I mean, obviously there's overlap. I think these people don't always fit the boxes that research trials create for them.
So on that, we do have one final polling question. We're going to finish in the next 10 minutes or so. So at the moment, she's on, Mrs. B is on inhaled corticosteroid and a long-acting beta agonist combination, the fluticasone propionate and the salmeterol, and a long-acting muscarinic antagonist, meclidinium, I think it was. So there has been a new player in the field among all those inhaler devices that we have, which is the single inhaler therapy, which is the ICS LABA and LAMA. So should she be changed over to that? So I'm going to ask all our participants tonight whether they think she should be changed over to the single inhaler triple therapy, or should she just remain on her what's called a multiple inhaler triple therapy regime. So here comes the polling question, which lovely people over here are going to put up, and it's a yes or no. Yes, she should be changed to the single inhaler triple therapy, or no. And then we'll ask Sally to give her opinion.
And then we have a few questions.
And then we have a few questions. Okay, we'll do that straight away afterwards. Now last. Okay, we'll get those up. A yes and a no. Please put your responses there. Okay, so you'll be very pleased to see that only 40% thought she should, and the majority thought no. Now, why shouldn't she be changed? Why would we suggest that she not be changed over?
In this particular person, I would suggest she not be changed, and the primary reason for this is that fixed dose combination has a fixed dose of inhaled steroid in it, and the fixed dose of inhaled steroid is a protective dose that's needed for COPD, but it may not be the appropriate dose that's needed for asthma, where she might need an alteration in her inhaled steroid therapy. Now, for somebody who just has COPD and not an acute bronchodilator response, changing to a single inhaler triple provides no benefit over the using two inhalers in terms of efficacy. The only real advantage is it's cheaper because you only have to pay for one rather than two inhalers. So my feeling in general is if somebody is on a stable combination and doing well on a stable combination and adherent to a stable combination, then changing to something else because it's new is not necessarily the best thing, because it's going to be a different device to one of the ones that she's using at the moment, and you're also potentially altering the steroid dose.
Now, if we've totally confused you about asthma and COPD and the overlap, there are some guidelines around, well, there's it's not a guideline, it's an information paper that is on the National Asthma Council website and also the Lung Foundation website, which gives a lot of information about that. So you've got some questions?
Yes, so the questions were clients FVC, I think this is in regard to the last case study, has reduced by approximately 20% in 3 years. Question mark should go to an ILD specific clinic or specialist she saw 10 years ago.
So go to an ILD.
So should this patient go to an ILD specific clinic?
Well, we don't know that this lady has an ILD. I think if the drop in the FVC over time would potentially raise the issue of a parenchymal lung condition such as an ILD, and that would be when you'd actually potentially measure your lung volumes, because the FVC on a forced manoeuvre isn't necessarily reflective. In severe asthma and severe COPD, you can get a reduction in the FVC due to premature airway closure from the inflammation. It shuts the airway so the air can't get out. So you cannot diagnose, you can say, look, it's reduced, but the diagnosis of a reduced lung capacity is based on total lung capacity, on full lung function testing, not on spirometry.
Which 2 years ago?
And 2 years ago it was normal. She's not got more symptoms. So it is an interesting question to sort of look at that change, and that's partly why the monitoring is important.
And what was the second question?
The second was just a general question about fibrosing alveolitis.
So fibrosing alveolitis is I'm trying to remember where that comes from. So basically, fibrosing alveolitis is an old term for what is now more generally called idiopathic pulmonary fibrosis. And so idiopathic pulmonary fibrosis is a parenchymal lung condition that involves lung scarring, predominantly starts in the bases, more common in men over the age of 75, and it's parenchymal lung, not airway involvement. Risk factors for idiopathic pulmonary fibrosis do include smoking, and so we do see a COPD, interstitial lung disease overlap. That's more, but it's a whole other area of discussion, which is sort of really, you may well see the risk profile is similar. So it's men over the age of, well, predominantly men over the age of 75, twice as common as women over the age of 75. Smoking is very common. Other occupational exposure is common. Symptoms, obviously, and respiratory, there's very few you can have, but yes, they may have cough, shortness of breath. So it can look similar, and that actually is one of the reasons why making a diagnosis of COPD is important, or not making a diagnosis of COPD is important, because if you have a person who has cough and shortness of breath and you treat them for COPD and they actually have idiopathic pulmonary fibrosis, you may miss an opportunity to give them antifibrotic therapy. So it's a completely different disorder.
And how are we diagnosing that on full lung function tests?
So basically, if you did your spirometry would traditionally be either normal in the early stages of disease or would show a restrictive defect, so decrease in both the FEV1 and FVC. They're ongoing shortness of breath. Then you would refer potentially to full lung function. The more classic things you see on that would be a decreased gas transfer plus a decreased total lung capacity. And the definitive diagnosis for idiopathic pulmonary fibrosis is a multidisciplinary review with a respiratory physician, radiologist and pathologist. But generally speaking, the diagnosis that's a predominantly radiological plus clinical diagnosis rather than, and the physiology supports it. Having said that, you can also have COPD, interstitial lung disease overlap, so the lung function might not be typical, but I guess it's if you've got symptoms that don't fit the severity of the airflow obstruction, then full lung function can be helpful because it can look at the parenchyma, and if you do show a decreased gas transfer, then probably the test after that is a high resolution CT scan to look for either emphysema or other parenchymal lung problems.
And there's treatments now for lung disease.
They're basically, if you've got idiopathic pulmonary fibrosis, I mean, this is really a whole another topic. So lung fibrosis is a big topic. Within lung fibrosis, there's the specific idiopathic form, and there's particular criteria for that. And for idiopathic pulmonary fibrosis, there are now 2 antifibrotic therapies that can slow the rate of lung disease. But they're very specific. They can actually only be prescribed after multidisciplinary review and through respiratory physicians because of the nature of those. They're not, and that also doesn't cover sort of other types of fibrotic lung disease, so occupational or autoimmune or other things like that.
We mustn't forget about lung cancer, the patient who has a change in a cough or a chronic cough. That might, these patients are at risk of, our patients with COPD are at risk of lung cancer as well.
Yes,
so
and so I think is change in symptoms. But I guess that's another thing to just briefly touch on, because often people will ask about the role of lung cancer screening. There's some trials from the United States have suggested a benefit from lung cancer screening. At the moment, it's not something that
There's a review going on at the moment,
yes,
which is concluding next month.
Okay, so there we go. But at the moment, we would say case finding is the more appropriate one. So people with a history of smoking and a change in respiratory symptoms should have the appropriate radiological investigation.
And that guideline's just been updated recently on the Cancer Australia website and through the RACGP as well. And there is a review going on at the moment by Cancer Australia, looking at the lung cancer screening, rolling out the lung cancer screening program, but the government might not have any money to do that now. So
and the downside of it is that a lot of lung nodules that are found need investigation, and that's
they're looking at all that. Downside. So were there any more questions? We've only got one more minute. That was it. Okay. So thank you everybody for being here with us tonight. Thank you to Rosie, who's just come back from maternity leave. So congratulations on that. Thank you, Sally, for your absolute expertise in being here as well, and your great presentation before. Thank you to Satmir for hosting this meeting and PHN for funding it, I think. So do our colleagues from Satmir want to say anything?
Just to check if there's no further questions from the participants.
Doesn't seem to be.
Yeah, wonderful. Yeah. Thank you very much for presenting for us. It's been a very interesting discussion.
Yeah.
And thank you to the PHN. There is an evaluation at the end of the session, so if you could just stay online. Anybody wanting to find out any more information about the health pathways, they're welcome to email us. And we can pass on the information to them.
Yes, yes.
Thank you, everybody. Have a good evening.
So stay safe, stay well, and we look forward to some nice warm weather and some sunshine. And to all the fathers out there, happy Father's Day for Sunday, and good night. Okay, thank you. Bye.